hoping the conversation now is going to be a little bit fun, and we're going to reflect a little bit upon the world we live in, which at the moment is quite a crazy world we live in, with everything that is happening in terms of war and oppression and marginalization within the world. This actually becomes a very relevant discussion. And although all our focus is around transgender people, for me, this is actually an example of the bigger issues at hand that we as a society need to figure out and need to grapple with. So I want to start by introducing a concept called a normative society. Some of you might have heard the term, but some of you, this might be a new concept, and I'm going to spend a little bit of time on that because being able to understand that there's this thing called a normative way and how society functions makes one a little bit aware of what of those people for which that society doesn't cater. And the reality is that if you're in a society that's normative for who you are, it fits who you are. So say, for example, you are right-handed and you live in a world that's built for right-handed people, it's invisible. You don't realize that the world is, for example, not friendly to left-handed people with the kinds of scissors that get sold or whatever. So being able to start understanding that there are very strong normative parts of society starts making us aware of what happens if you're not fitting into that so-called norm. So some normatives we're all quite aware of, actually. So the classic thing we're all aware of is male as normativity. So we're all very aware that a lot of language that's still being used, a lot of societal structures, the way we set up our schools, the way we set up our work environments is very much still the way men has set up the world and men has run the world. And even hear me, for us, as for those of you that are men, you are all comfortable with this is something that has happened and this is something we need to change. So we're trying to build a society that is more inclusive and more accepting also of women. And we actually got Women International Day at the moment. And how do we start becoming aware of these norms that are automatically there? Easy. The next thing is normative whiteness. And in South Africa, we are very aware of normative whiteness. So we're aware that we've got social, systemic cultural processes that's been dictated by colonialism. And the classic example is, for example, if you've got a young girl who lives in Lusikisiki, where her family and her ancestors has been speaking isiXhosa for hundreds and hundreds of years, but if she wants to get a qualification in this country, she has to go through a schooling system that's very similar to what the British schooling system looks like, and she's going to have to write her matric in English. If you're English speaking yourself, this is not even something that occurs to you, that about how strange that is for you to do this qualification in this very European language from another, not even from this continent. A lot of our professional dress codes has been very much dictated by the West and the white world. And the classic thing is toys. You know, if you look at the balance of toys that there is, the majority of toys, majority of action figures are all going to be white. And if you noticed, even if they have a black Barbie or an Indian Barbie, they will have exact white features, and then they just change the color of the doll. So these are normative things, which again, as a white person, there's sometimes things that we don't even see and are not even aware of than somebody, for example, a person of color might notice in the world we lived in. We're all comfortable with it. This is something that we're working on. Able normativity is also one of those concepts that I think we're all very comfortable with. We realize that our world is not built. If you can't walk, if you've got chronic illness, if you can't see properly, if you can't hear properly, you're going to struggle to find your way through the world of today. And there's a big drive to try and create more inclusivity for disabled people, having disabled walkways, having disabled parkings. But quite often it's also abled people who decide what is needed, and they don't even realize a lot of the barriers that disabled people might be finding as they move through the world. So able normativity we're also used to, and we are trying to work with that. Not so well known is neuronormativity. So this is a different concept to think about. So this is a world that we've created, the way we communicate in our world, what we consider important based on the neurotypical way of looking at information. And what I'm talking about here is we're not very inclusive for people who are autistic, people who have ADHD, people who are dyslexic. And you could almost even fit a lot of your mental health illnesses in here as well. So for example, the classic thing is when you go through an interview, it's all about how gregarious you are, how well you can make eye contact, how firm your handshake is. And we have these very particular normative ways in that we consider is considered the normal way to be. And this is something also that will need a lot of education for us to be able to understand. Okay, I think we're all still on board, right? So let's stretch that normativity concept a little bit. And some of you might have heard about heteronormativity or cis heteronormativity. And it's helpful to understand, just as we consider the world as being male, white, abled, and neurotypical, we also assume that everybody we meet is straight and binary. And if you look, for example, at educational materials in schools, the way we teach our children is that a couple is a man and a woman. A family is a man and a woman and their children. Quite a lot of our adverts, quite a lot of our media has this typical view of what the world looks like. Male-female bathrooms, that still exists very much within our society, is also a good example of this. And again, if you yourself are straight and cisgendered, quite a lot of these things are invisible. You don't even notice that there are some things that's only representing who you are. If you are ever within that LGBTQIA plus group of people, you are constantly aware that the world doesn't cater for people that are like you. Now I'm going to stretch it just that little bit further. So I find generally people are with me. Yeah, no, I get it. You know, we have to become aware. The next thing is Christian normativity. And I find sometimes here people find that a little bit more challenging. And this is the idea that, for example, in a country like South Africa, is that Christian worldviews, again, is what's largely catered for. So a very good example is the fact that our major public holidays, Easter and Christmas, are both Christian holidays. So if you're Muslim or if you're Jewish or if you're one of any other religion, you're not necessarily going to get, well, you don't get a public holiday that's specific to your religion, and those religions aren't even generally recognized within most of our society. Advertisements, for example, or what gets hung up in the shops. Again, within educational focus, there's a lot of focus where we use Christian language and then also Christian values and norms. What I find interesting, and this is a little bit of reflection, is that Christian normativity, some Christian churches, and not the majority, but there are some Christian churches who considers being gay and being trans as a moral Christian for Christians as an issue. And this actually has an effect on cis heteronormativity. So it's the idea that this kind of way of being is the only right way of being. And if you do not sit within that particular worldview, you find yourself again falling off the edges. So just to become aware of normativity, and we're gonna play with some of these concepts going forward. So the next concept to think about is marginalized population. I'm sure you've all heard the word marginalized. Not all of you might know where that comes from. It actually refers to what we call the power wheel, and it shows us how some people have unearned privileges that puts them closer to the center of power. And with power, I mean, how much power do you have to change your own life? And how much power do you have to change the society that you live in? And to be able to change things, you need to tick several of these boxes. If you are sitting on the margins, the further you are away from the center of power, the more you are towards the margins of a society. And intersectionality says that the more of these that intersect, the more vulnerable you become and the less power you have to change things. I always use Trump as an example here. So Trump is somebody where you can see he's a citizen in his country, he's a cisgendered man, he's English, he's rich, he owns property, he's got, I'm not sure about mental health, but he's neurotypical, he's heterosexual, able-bodied, and he ticks almost all of those boxes. And this makes it much more likely for him to have an extraordinary amount of power that he can exercise within his country. He's much more likely to raise to the ranks. What's been interesting with Trump is if you look at what we traditionally talk about on the margins, these are the exact people that he is currently persecuting. So people of color, people who are undocumented, people who are transgender and non-binary, people who are non-English speaking or poor, people with autism, for example, with neurodiversions, your gay, queer communities, and then also people struggling, for example, your Medicaid affecting people with disability, etc. So you can see here these marginalized communities. If you are, say, for example, a person of color who is transgender and maybe undocumented in the USA, you're extremely vulnerable in terms of how much power you have in what happens in your life. So another concept to build on top of that is the concept of how people therefore view society. And this is very much based on also our own need as human beings to have a survival of the fittest in the world that we live in. And this can, on that survival of the fittest perspective, you can build this elitist view. So elitist views is what we are seeing at the moment in the USA, which is the idea that some human beings have more value than others. And what happens when we look at that center, that power cycle, is that those on the center, they decide who's acceptable and who's not acceptable. So Trump has basically put everybody that's like him onto the top of the powers triangle, and he's deciding who exactly are not going to be sharing in the resources. So whenever you have a system there's classification, marginalization, discrimination, oppression, apartheid, South Africa is a good example, Nazis in Germany, etc. You are talking about a group of people with power that has this elitist view. And the sad thing is actually that's the way the world has always rolled, right? That's pretty much how we operate. In the last 100 years, and we've just seen the death of Reverend Jesse Jackson, we are seeing the arising of this idea of egalitarianism. And South Africa is one of the leading thought countries in the world around actually having an egalitarian constitution. An egalitarian view is the belief that all human beings have equal value. Radical concept. The world has never worked like that. And the idea is then, how do you create a society where everyone has opportunity and is able to participate? And the Freedom Charter in 1955 was absolutely radical as a document, where this was the purpose of revolution, not to put somebody else in power, but how to create this truly egalitarian society. So we've sort of had the way the world's always worked, which has been very elitist. And you have these hierarchical societies that's usually a pyramid. And you've got your very powerful people sitting at the top. And although we know that monarchies, the caste system has always worked like that, but actually capitalism is also that pyramid. And I think that's the challenge in South Africa. So we have this lovely egalitarian vision in our constitution, but we have this very strong capitalist system, which means the more money you have, the more power you have in South Africa. No matter where we say everybody's equal, but if you don't have money, you do not have the same power in society. What we dream about is an equalitarian society. And then you start hearing these egalitarian principles, words like diversity, equality, equity. How do we get everybody around the table? Inclusivity. How do we make a place for everybody? And when we start talking words like democracy, liberalism, and human rights, we are starting to draw on these principles. And they are new concepts. They are young in the world of today. So when we're doing a talk about ethics, we are always talking about egalitarian principles. So a hierarchical elitist society does not have ethics because they do not recognize the autonomy of the human being. So the third concept I'd like to introduce is around positionality. And it's a little bit to understand personal worldview. So one of the words that get thrown around a lot whenever we're trying to write guidelines and things is this concept of bias, right? And we've actually been attacked. The guideline has got, I've shown you, is endorsed by lots of transgender communities. And there was actually transgender healthcare professionals on the group of researchers that wrote the South African HIV Clinician Society guideline. And then the anti-trans movement has accused that of being biased. But I just want to unpack that concept. So as a human being, you have a view of other people. And there are two things that informs that view. The one is lived experiences. Where you grew up, the people you grew up with, the language that you speak, the kind of people you studied with, the university you go to, that is what you know. And our lived experiences actually gives us a very complex understanding of that world. So if I use again let's say the girl who grew up in Lusikisiki, she will have a very deep understanding of rural living within Lusikisiki, of the isiXhosa culture and her people that she grew up with, and she will understand what that community is all about. If she meets somebody else from a small rural village in the Eastern Cape, she's more likely to understand a little bit about who they are and where they are about. But in our very global world today, you do obviously run into people that you have never had any contact with before. You have no lived experiences. And we call this these bias-driven assumptions we make about people that we may never even have met or spoken to. And for me, transgender people are such a good example. So a lot of people who have very strong opinions on what transgender is people who have never actually met a transgender person in their entire life. And these are socially shaped, quite often unconscious beliefs. So things that you hear, things that mom says in the kitchen, things that gets mentioned at school, things that your friends say. And it sort of creates part of your worldview of how you think things work. The reality is when you meet people who are not like you, we tend to be a little bit less understanding, and we tend to have a very homogenous view of what people like that are like that. So a big concept is actually the disability. The disabled people brought this very much into the front, or people with disabilities, is that if you're going to build structures, if you're going to write guidelines, for example, if you're going to decide how to make things more accessible, nothing about us without us. And for me, whenever you are having a committee to decide, for example, about a particular group of people, there has to be knowledge of the lived experiences that feeds into that decision making. And we have to watch out with biases from people who actually don't know these communities coming into these spaces. So transgender people is a very marginalized population in South Africa. There are few of them, and with this unequal distribution that there is between those with power and those with don't have power, if you are transgender, you're going to have barriers to healthcare, you're going to have barriers to education, you're going to have barriers when you try and get a job, you are going to be less safe, and there's a much higher risk of stigma, violence, psychological distress. So you become vulnerable simply because you have told people that you are transgender. If somebody is the opposite of that, so if you've got a cisgendered male, white, middle-class, able-bodied person, these inequities are actually invisible. We don't see them because it doesn't affect our lives. Trans spaces, of course, is also very homogenous. So with that intersectionality, if you're a transgender person who is, for example, highly educated, well resourced in terms of money, white, you will have more power in terms of being able to do things than somebody, for example, who is poor and from a rural community. So I'm going to give you a couple of reflection things just to think about in terms of the going forward. And just in terms of transgender people, so where does your lived experience place you in terms of understanding transgender people? How many transgender people do you know? How many have you provided services for? How many have you actually met? How many do you have first-hand experiences of what their lives are like? And you yourself might be a transgender or gender diverse person. Also then become aware of what if, especially if you haven't had much contact with transgender people, what is forming your views about transgender people at the moment? What have you been taught? What have you heard? And very importantly, whose opinions were that? Whose opinions have informed your current framework that you have around transgender and gender diverse people? And for me, this becomes important. So we need to reflect on our biases. Yeah, we all have our little things. But to start becoming aware about how much power do you have, especially as a healthcare professional, to actually impact on the lives of transgender patients that might be coming to your facility. So let's move on to the actual ethics part of the talk. I'm just checking my time. Pierre, I've got till 10 to 7, just for the record. But ethics speaks about these philosophical studies of these moral right and wrong, and they're very much based, as I've said, on this egalitarian principle. So underlying ethics are that human beings all have the same value, and you can't, you have to be respectful of that. So the values that we're going to look at particularly informs the ethical principles around the care for transgender people is the GAHC principles. These are a human rights, international human rights law that South Africa has signed up to and talks about this right to bodily and mental integrity, autonomy, and self-determination. Person-centered care is very much a South African concept around the concept of Ubuntu and creating a person-centered, patient-centered care that responds to the needs of that particular person that's sitting in front of you. And then the HPCSA ethical guidelines very much talks about recognizing the intrinsic worth, dignity, and value of the human beings that we are looking after. So the HIV South African HIV guidelines on gender affirming care actually has these very particular, and you can see these are all egalitarian principles, which I've mentioned earlier as well, affirmation, dignity, equity, inclusion, etc. So now it's ethics talk. So we're going to go through the 4 ethical principles and we're going to apply it to our particular population. And we're going to start off talking about autonomy. So it's interesting with autonomy because quite often people will use autonomy as a reason to say whatever they want. Freedom of expression, we're allowed to spew whatever hate we would like. And it's kind of helpful when we've talked about normative societies and we've talked about this power cycle to realize that freedom of expression is not an equal playing field. So the opinion of those in power are much more different than the opinion of those that are marginalized. So, for example, Helen Ziller having an opinion about transgender people and celebrating the UK ruling that there are only 2 sexes, etc. That in itself is scary because she has influence over policy. She has influence over what is going to happen, for example, within the areas where she has reach. So there's a difference between simply being able to say freedom of speech, as we said, and this freedom of reach. If you have freedom of speech without ethics, so if you're not respecting the autonomy of other people, if you're not respecting and trying to do good and not do harm, then that is what we equate to hate speech. And we're trying to firm up the laws around this opinion of those in power. So in terms of autonomy, the HBC ethical guidelines are very clear that we honor the right of self-determination. We are only there to give advice. The patients can decide to make their own informed choices and to live by their own beliefs, values, and preferences. This is what we want to do for healthcare professionals, for our patients. This is also what you want when you go to your doctor. When you go to your doctor, you don't want him to tell you how you're supposed to live your life. So there's specifically under that, the HPCSA talks about the fact that we need to be aware that our personal beliefs do not prejudice our patients' healthcare. And then they've got a whole list of all the different things you need to consider. But any condition that might make your patient vulnerable, you have to make sure that your own biases don't start playing into that care. And so if you feel you can't, that's also okay. If you feel that from your particular view of the world, this is something you don't get, you don't understand, you can't sign up to it, that in itself is also your right to self-determination. But then you have to make sure that your patient has a safe space that they can refer them to a healthcare practitioner that's able to provide that kind of care. So when we actually think of autonomy, this is actually the ethical principle that is the most I would almost say at risk when we're talking about the rights of transgender people. So when we talk about the rights of gay people, for example, it will be framed about whether you're allowed to or not allowed to be attracted to the same sex, for example. But transgender, the anti-trans movement is slightly different with transgender rights, is that they deny the trans experience. So they try and invalidate that there is no such thing as being transgender. It doesn't fit into our worldview. And this is a direct breach of the autonomy and self-determination. So they are saying we will not listen to what trans people say because we believe that their ideas are not valid according to that worldview. So we're seeing at the moment what happens in the world if we do not respect autonomy. And this is what's been happening in the USA, it's also in the UK, where they start classifying these 2 binaries. It reminds me a lot of the apartheid government that created these arbitrary classifications of race, for example. And then once you've classified people, then you start framing that as a threat. And we are seeing this already very much with transgender people in the USA at the moment, facing terrible persecution. So when we also talk about autonomy, we also always talk about informed consent. This is a very important model we're going to talk about a lot in the next webinar. So in the old days, there was a bit of what they called a gatekeeping model, and this was quite stressful because the idea was that you as the healthcare worker would have to decide whether the patient is trans enough to go on to hormones. And then if things didn't work out, then clearly you made a wrong call. We now have moved completely away from that model, and now it's all about informed consent. You are there to provide the patient with enough information. It's a collaborative decision-making. You give them enough information for them to understand what's going to happen, but the patient takes responsibility for going on that treatment. So the gender affirming guideline, as I've mentioned earlier, has been very respectful of the autonomy of the trans community. And so we have transgender voices that's actually been part of the writing of this guidelines. I'm also going to tell you about some amazing evidence that's also that we now have that further strengthens the recommendations. We've got very solid research now to strengthen these foundations. Great, so that's autonomy. If we go on to our next one, beneficence, which basically talks about, they always say about doing good, but this is basically the idea of evidence-based care, right? Don't give your patient stuff that doesn't work. So you've got to make sure that the stuff that you are doing is actually going to benefit your patient. It's a little bit getting away from the snake oil time where you just give things to make your patient feel like you're doing something. And it's seen as an act of kindness. There's a moral obligation. If you know that there's something you can do to help, then you need to help your patient. So, of course, under this is always the evidence-based question then, is gender affirmation, because when we talk about transgender people, this is the main intervention that we're talking about as doctors, is it beneficial to our patients? So just to remind us, when I'm talking about gender affirmation, I'm not just talking about hormones. I'm talking about using the correct name as chosen by the patient, using the correct pronouns, being sensitive in how you take a history and examine your patient, being aware of your healthcare facility. We're going to talk a bit more about that later. Just validating what your patient's telling you, even if you don't get it. Yeah, you, and I'm accepting who you are. And then gender affirming hormones is another form of gender affirmation if you can't provide it by referring somebody to that is able to. And then there's a whole range of gender affirming practitioners. So you can refer to a speech therapist, you can refer to a psychologist, you can refer to a surgeon, and all of that is affirmation and practices for your patient. So evidence. So this gets interesting. So I thought I'd put a slide in specifically around evidence in gender affirming care because it's been interesting to see how anti-trans people have tried to attack the evidence. But there's a few things you need to consider when we talk about the evidence in gender affirming care. And the reality is that in the so-called world of evidence, there's the golden RCT, the randomized controlled trial. Randomized controlled trials is not always appropriate. Although it's a very high level of evidence, it's not necessarily always the best type of research. So this is a very good example. So if you are giving somebody hormones, it's impossible to placebo it. You can't go and give some people hormones and some people placebo and see what happens. It's going to be very clear on who's getting the hormones and who's not getting the hormones. So RCTs are just ethically not possible. There's also very complex individualized pathways of what people need with gender affirmation. So it's very easy if you're wanting to measure, amoxicillin for 5 days and does it cure a UTI or whatever. But for gender affirmation, there's too many different, it's too complex to do a simple RCT on, for example. So different types of studies are needed, and we're seeing a lot of prospective and retrospective cohort studies, qualitative studies, cross-sectional surveys. So this is different type, and there's a lot of studies that's been done out there to observe what happens with people who are getting gender-affirming care. An unfortunate thing in the world of today that's happened, but has partly been helpful from a research point of view, is that, for example, in the USA, there are some states that are providing gender-affirming hormones and some that now do not. And so one can potentially follow up people over time and see what happens and compare, and we have some data on that as well. The other challenge is that for big trials, we want lots of numbers, right? You want huge amounts of people to be able to make statements about things. But the challenge is it's a very small population of people who are transgender, and not everybody of them take hormones. Not all of them are actually even accessing care in our facilities. They're very vulnerable people, and it's quite challenged. How do you recruit people into a study? How do you sample out of those people to decide who's going to get treatment and who doesn't, for example? And so you'll always have small studies wherever you go. So you have usually some of these cohort studies, surveys, and small groups of people. This is not uncommon. For example, in pediatrics, there's a lot of sort of uncommon medical illnesses in pediatrics, for example, which is this exact kind of scenario. It's not always ethical to be doing RCTs on children, for example. They're quite often very small percentages of children, for example, might get something like leukemia. And this is where it all gets interesting, because there's been a very strong political, active right-wing anti-trans groups that's tried to attack the evidence base for gender affirming care, which is kind of ironic because we have excellent evidence. I will show you in a moment. But what they've been doing is they're trying to say there's this lack of evidence because there's no RCTs, because there are small numbers. So they try and attack individual studies like that. But actually the underlying goal is to oppose the implementation of gender affirming care. So there's groups in South Africa who's actively trying to undermine us ever implementing gender affirming care in this country. And so you have these weird debates about there's no evidence, there's not enough evidence, but. So as part of a response to this continuous narrative from the anti-trans groups, it always makes us work a little bit harder. There's been an extraordinary publication that's going to be published in the HIV Clinician Society journal quite soon. There's already a preprint out of the full document. It's a rapid review of gender affirming healthcare for children and adolescents. And they've looked at all the evidence globally from 2021 to 2025. And you can see they've looked at all studies, and these would have been studies that's obviously trustworthy and evidence-based studies that reported psychosocial, physical health outcomes, endocrine, surgical, non-medical, policy, legal interventions. So any study that had more than 5 people in the study and that clearly showed an intervention and looked at whether an intervention was helpful or not. And they looked at the whole range of gender affirmation types of things. And they looked specifically from 12 to 18-year-olds. And this mainly because that's the group in which there are materials available. And you can see there, they managed to obviously had thousands of articles in the original search, but after they've gone through them, there was 200 primary research studies. There was 29 academic systematic reviews, 4 grey literature systematic reviews, and it's a beautiful 131-page document that is unpacking everything that was within this guidelines. I'm going to show you some of the things that we now know about gender affirming care. Here are some of the other amazing systematic reviews and researches that's been coming out both locally and globally. And what's interesting is that, yes, an individual study is difficult to believe if it's very small numbers and if it's a cohort study or whatever. But if you have 234 studies that all say the same thing, that becomes extremely powerful evidence. And what's very clear is there's no contradictory evidence. It's not like they're saying, oh, there's quite a lot of evidence that says that it's good, and there's some evidence that says that it's bad, and we need bigger studies. All the evidence is exactly the same thing. The evidence are very clear. Gender affirmation is an extremely powerful intervention for doing good in transgender and gender diverse people. And this includes improving adherence to HIV prevention and antiretrovirals. That was a South African study. Improving the quality of life of transgender people, improving their social functioning and their sense of belonging in the communities. There's very good data in terms of a decreasing depression and psychological distress and anxiety symptoms, decreasing suicide risks, reducing risky behaviors in these groups, and increasing their access to healthcare services. So simply by respecting, validating, and affirming a patient's identity, they must have the right to make their own decisions, and being able to refer them to the appropriate or interventions that you might have available shows massive improvement in quality of life. And there is no debate about this. Most of the debate that the anti-trans people come is trying to say you don't have RCTs, you don't have big enough numbers. But all the evidence that we have is very clear. Gender affirmation is extremely powerful. So the next axis is non-maleficence, which is basically now, if you're going to give something, just make sure it's not causing any harm. So we're actually talking about side effects and complications. And you therefore need to know, okay, what is the risks of this treatment? What is the benefit? And you have to be able to weigh the two against each other. So if you've got something that you know helps, but it's got massive side effects, for example, then maybe the harm outweighs the benefit. So non-maleficence looks at what is the risks of getting this particular treatment. And I'm going to focus on 3 aspects of this. The first is just remember the risk of not giving gender affirming care. So that in itself must be considered. It's not a neutral event deciding not to be affirming. Then we'll talk about the actual harms of the hormone treatment specifically. And then I just want to talk a little bit about what actually happens when we say that they do not allow, that we should not be affirming transgender people. And we'll talk a bit about stigmatization. So firstly, in terms of the risks of not providing care. So there's lots of evidence around this as well. And what's lovely is that one of the things that's come out of that rapid review is very clear the risks of being neutral, of not doing anything, but also very much the risks of conversion therapy. So we now actually have good collection of studies that tells us about what happens when we try and force transgender people to, when we don't believe transgender people and try and convert them. And what we definitely know is if we don't provide gender affirmation, we see much higher depression, and very worrying, we see much higher suicide risk. And we ourselves have had scenarios here in the Eastern Cape, a teenager child who committed suicide, and the parents had not realized the stakes that was happening at the time by refusing to affirm this child's gender. So it's just a little bit, we need to be aware that simply doing nothing carries burden for these people. One of the big things that's concerning from a Department of Health point of view is that we do not affirm patients, they don't come to our clinics. So actually a lot of the things that affect their health care is actually they don't get proper care for their HIV, they don't get proper care for their diabetes, they don't come for their screening tests because they do not feel safe coming to our facilities. We have to talk about risks and complications, and I have to say hormone therapy is very in terms of massive side effects or complications. Feminizing treatment, it's like giving contraception, right? So we provide millions of women every year with either contraception or menopausal women with hormone replacement therapy, and the potential side effects and risks is very similar. They might get a bit of headache. We're always worried about venous thromboembolisms, but the risk is no higher than in providing contraception. So if we're happy to provide contraception, we should be comfortable to provide estrogen for our feminizing treatment. There are some changes to the sexual response cycle and libido, and I'll talk quite a bit about that in our next webinar. But the only thing that really is where the rub is, and this is where the conversation is so important with your patient, is that it doesn't happen overnight. But eventually, if you stay on estrogen for many, many years as a trans woman, you will eventually become infertile. And so this is an important conversation to have. But this is not something that happens dramatically overnight. So it's something that needs to be an ongoing emerging conversation. In terms of testosterone for our trans men, so it's a bit like it's exactly like going through a male puberty. So acne is a big testosterone challenge. So they might suddenly end up with some very bad skin. And what's interesting is that remember, estrogen is protective in women in terms of heart disease before menopause. So if you are taking testosterone, you will have the same risk of cholesterol and the same risk of hypertension of a cisgendered man of your age, for example. The interesting side effect we sometimes see with testosterone is polycythemia. So that's when your blood count goes up. Very easy to treat. They must just donate blood. So it's very simple to monitor for and very simple to manage. But again, over time, at a trans man, if you take testosterone for many years, you're going to end up infertile. And that's therefore, again, a very important conversation that you might not be able to have. You won't be able to have your own genetic children unless you've pre-frozen either eggs or sperm. So the idea is that, so the concept basically between maleficence and non-maleficence is that there are definitely always side effects and risks. These need to be discussed with your patients, but not doing gender affirming care in itself is not a neutral act. And so there's this extraordinary benefits of gender affirming care, and these risks and harms need to be explained to your patient. The third aspect is just the concept of saying that we need to look after our transgender people. And there's an extraordinary amount of transphobia in the world of today. And this causes, there's this concept of minority stress within the academia, of how this continuous living in a normative world, a cis heteronormative world where you are not safe in lots of different spaces, and you don't even always know where you are safe. And there's a very complex interplay. And if we are not providing gender affirming care, if we're not making this available, we are feeding into the stigmatization of gender affirming patients. Great. So our last principle of the 4 is justice. I'm doing well for time. And there's 3 things usually under ethics when we talk about justice. Distributive justice is making sure that everybody has access to care. And so for transgender populations, it's actually meaning just having them access to gender affirmation. So access to hormones, they are very cheap. This is a very small population. I must say this is not going to make or break our healthcare system. But access to surgery is a much more complicated question and concept of how do we make that available on the public sector. Interestingly enough, a little bit of food for thought. So in Mthatha, there's been some interest in terms of gender affirming surgery. So that you won't end up doing very many gender affirming surgeries. A very small amount of people might actually want those. But the plastic surgeons became interested because of the kind of skills they will gain by learning this. And in the Eastern Cape, specifically around, for example, creating a penis with, unfortunately, some of our young boys that might end up having had sepsis. And so there's a skill set there that's actually useful within other populations as well. And it suddenly creates us access also for our transgender patients. So it's a little bit of interesting things to think about from a justice point of view. From a rights-based point of view, is this really looking at how do we prevent discrimination within our facilities against our patients? And then on legal side, this legal right to actually change that gender marker and that right to recognition within the healthcare system. So if we look in terms of our milestones towards gender affirming care, an important concept is that of depathologized. I can never say this word, but taking the pathology out of this. So we had the same thing with homosexuality. So homosexuality for many years was considered a disorder in our DSM, had like classification. And we have long since taken homosexuality out of the DSM. And the same has happened. So transgender also used to be considered a disorder in the old DSM, the DSM-5 in 2013. This word gender identification disorder was changed to gender dysphoria. So that's just that experience of not fitting in your there's this incongruence between the bits that you have and your inner experience of gender. The ICD-11 also now has the term gender incongruence, very similar term. And actually the WHO actually felt it necessary. So from a science point of view, in 2019, to make it very clear, this is not a mental health disorder. It does not fall under psychiatry. It's not in any of our psychiatric textbooks. And therefore, we are now looking at how do we include this diverse group of people in our clinics, for example. The challenge is that initially under the NSP and under our focus in terms of providing services to our gender affirming people and making all of this possible, so there's been very much the will for it, has all been provided through the NGO sector, and that got very badly pillaged last year. So there's always a question about transgender youth. People get very nervous when we talk about children. When we talk about kids, remember transgender is something that your brain gets wired like that already, usually before birth. There's a very strong genetic component, at least about a 40% genetic component. There's other factors that can play in, such as pregnancy hormones, for example. And then the child will slowly discover as they grow up that hey, something's not right. Okay, the way I feel inside and what's happening within my body, these two are not matching up. Some kids know this quite young. 3, 4, 5 years old. Some kids only start noticing it once they start going through puberty. And of course, when we start working with children, children has an emergence consciousness. They have an emergent identity information that takes them a while to figure out who they are and what they want. And therefore, this is not as simple decision-making as you would with an adult. And very important is that this has got a lot of complex things that need to be considered. There is no Mickey Mouse instant, this is what you do with a transgender child. And so what you need is expertise. So if you, for example, have a family where the child has come out as transgender, you want to be able to slot them into a gender affirming network that has got high level of expertise and a full multidisciplinary team. So with a transgender child, you want to have involved a pediatrician, you want endocrinologists, you want a child psychiatrist, you want a GP, and you want the parents must be part of those conversations. You want to use support groups with other families. You want to provide spaces where we can understand and help the child figure things out. I'm not going to talk about puberty blockers tonight, but puberty blockers wins us a bit of time for the child to figure things out, especially if a child's getting extremely distressed going through puberty, for example. It needs to be aware that the parent needs to understand that there's two different communities. So there's the gender affirming community, which are these multidisciplinary teams, But there's also a trans non-affirming community. You all know where I'm lying, obviously, where transgender is seen as either an illness or a confusion or an ideology. There's this main intervention that's aimed at conversion. And it's very much fear-based. So there's this specter of social contagion. It's a bit of a vicious cycle, right? So a terrible thing to be is transgender. And so therefore, we don't want my children to get transgender, and I'm not sure how it happens. So now we discriminate against the transgender child, and we don't want them to be transgender at school, which makes it even a worse thing to be transgender. So you have this interesting thing where we demonize transgender people. And quite always the people who are within these communities who are using conversion are always cisgendered people, and they usually have no expertise, and there's no trans representation within that decision making. So when we don't have ethical principles, we see what's happening at the moment in America. So for example, in Kansas, they are transferring the transgender women, for example, to male prisons. They are taking away their hormones, and they want to do a research project. Apparently, they're busy fighting it in the courts on forced conversion therapy on transgender people within Kansas. And this is literally what happened within the Nazis. We're also getting very concerned that America is using like an economic blackmail by their ideas and ideology around persecuting transgender people, trying to force NGOs, even in South Africa, to persecute and marginalize transgender people, or they will not get funding. And this is a very challenging scenario we're in. And we've even seen now that they're trying to, in Kansas again, if you're, say you're a trans woman and you've got a driver's license where your gender marker is now female, you were assigned male at birth, they're revoking those driver's licenses, and they were trying to take 1,500 driver's licenses away. So this awful results when you don't have ethics. So just the last couple of slides in terms of why we want to making the case for gender affirming healthcare as an ethical prerogative. And being transgender is not an illness or a disorder. But hormone therapy is obviously a medical treatment. So we have that interesting ethical thing. Why are we giving people who are not ill medicines? And the parallels you can think about is we quite often use things, medical procedures or treatments that is actually, one could say, to support a particular person's life. So that can be traditional circumcision, hormone replacement therapy in postmenopausal women, contraception, giving us the right to have sex, right? It's the only thing it really does, sterilization, TOP, all of the cosmetic procedures. All of these are scenarios where the benefit to the person's life outweighs possible risks. And we know that gender affirming health hormone treatment is very contributes to the well-being of our people. It's cheap, it's got few side effects. Most of the effects are actually reversible, which is actually a problem. So you stop your hormones and go back to where things have been. And then just this fertility is the only thing we really want to talk about. So my last thing I want to talk about is people always come up with regret. Now, just to remind you, regret is not an ethical principle. There's no other medical procedure where we think about regret. And of course, regret is common. There's definitely a chance that somebody might decide in the end hormones is not going to work out for them. We've got regrets for tattoos, we've got regrets for marriages, we've got regrets for having children, there's regrets for knee surgery, there's regrets for TOP, there's regrets for having vasectomies. And our responsibility is we can't try and predict what if the patient ends up not being happy. And that is where this respecting of autonomy and self-determination, you're just there to give information, and the patient carries responsibility for the outcomes. That saying, the regret rates for transgender people are probably lower than almost any other procedure that we have in medical care. And most people who do transition usually don't regret even having gone onto the treatments. But we'll talk about consent properly next way. So going forward in the next year, you're definitely going to come across a transgender person. And just becoming aware of your own views. Are you going to bring an elitist perspective to that person in front of you? Or are you going to bring an ethical perspective, respecting the equal value of all human beings and affirming the gender of that person? Thank you very much. And feel free to put questions and comments in the chat. And Pia, you're very welcome to interact on the chat with people if there is a need. I'm going to just get up the last